Okay, so the diagnosis and treatment of cancer. And then in the last section, we're going to talk about more specifically physical therapy related to cancer. So diagnostic tests, of course, there's routine screening for early detection. And those are the sort of things like getting a colonoscopy after age 50 and the routine blood tests that your doctor does when you go in for your yearly exam, that sort of thing. So sometimes they'll detect things like blood abnormalities and things like that with the routine screening. Self-exams, breast and testicular and skin examinations are the kind of self-exams that we can do to, if you do it consistently, you can detect problems early. Blood tests that you might get at your regular annual exams, they measure blood cell levels and they might detect tumor markers like the PSA test. So there are some established routine screening tests that they'll do at certain stages and certain ages in your life. Once they're trying to visualize changes in tissues or organs, they're going to use x-rays and ultrasound and MRIs and CT scans. Once they've localized a tumor, they might use cytological tests that require a biopsy or a cell sample. Basically, they get a sample of the tissue and look at it under the microscope. The tissue might be tested for growth promoter sensitivities. Like estrogen can be a growth promoter, and they can detect kind of what kind of tumor it is. Cytological tests are most dependable for confirmation of malignancy. So it's going to get there eventually. So the treatment is going to depend on the specific cancer. It could include surgery, chemotherapy, immunotherapy, radiation, a combination of all those. There are other treatments that include bone marrow transplants, hormone therapy, targeted therapy. There are new treatments being developed all the time. Okay, so surgery is the most common intervention for solid tumor cancers because you have something that you can remove. Surgery was really kind of the first treatment for cancer. Even cancer's been around for a really long time. So even in like ancient Egypt in the Greek and Roman times, doctors were trying to do surgery for external tumors to help prevent them. But tumors were, and cancer in general, was considered to be incurable because even when they did surgery back then, it often came back. And, well, we know why now. But the type of surgical interventions that are done now, one is preventative to keep the cancer from reoccurring. Or from occurring at all. So if you have a precancerous growth, you do surgery to get rid of it so it doesn't develop into cancer. Diagnostic, so to remove some or all of the mass to examine it and see what's going on with it. To stage it to determine the extent of the cancer. Curative, to remove the cancer, and that's often followed by radiation or chemotherapy. Supportive, to support other methods of treatment. So they might use radiation to shrink the tumor and then do surgery. Or palliative, which is not meant to cure but to alleviate pain or disability and or improve quality of life. So that might be like a tumor debulking where they decrease the size of the tumor so it's not pressing on local structures. Radiation therapy uses high energy radiation. The purpose of radiation is to shrink tumors and kill cancer cells. So it can be used as curative or palliative. Different types of radiation therapy. We're not going to talk about specific types, but external beam, where there's an external source and they're applying the radiation externally. There's internal radiation therapy, which they actually place a radiation source inside your body. And systemic radiation therapy, where the person receives a radioactive substance by swallowing or receiving an injection. So different types of radiation therapy and different precautions with those different types of therapy too. So with external beam, it only affects the body for a brief moment, and there's no radiation source in the body. So the person can't contaminate anything or transfer radiation to others. So there are no associated precautions with external beam radiation therapy, which is good. But with internal radiation therapy, where they have an implant, while they have that implant, they're usually hospitalized, but their body may give off small amounts of radiation, so they can contaminate items and people around them. You might get a permanent implant. With the temporary implant, they're probably hospitalized at the same time, and that's probably when we're going to see them in PT. With a permanent implant, they need to keep their distance from children and pregnant women. And this is also with systemic radiation therapy, swallowed or injected. The radiation is going to be in their body for a few days, and they're probably going to be hospitalized during that time. And they're going to be treated in a shielded room, and their drugs are kept in specialized shielded containers. There was a case in Bellingham a few years ago where someone was getting systemic radiation therapy, and they were going across the border. Well, when you go across the border with the radioactive materials, it's going to set off a whole bunch of alarms because you're not supposed to transport radioactive materials across the border. So if the person was living in Point Roberts, and so they had to go across the border twice in order to get home from their cancer treatment, and they so that's always the thing where you need to have the good documentation from your doctor so the border guards know what's going on. Generally for internal radiation and systemic radiation, precautions last a few days after treatment. You really want to, if you're treating a patient who's getting this, you want to consult with the radiation oncologist and the oncology team for specific information for that person. Generally, you need to stay 1 arm's distance from other people who spend more than 2 hours in any 24-hour period. So a nursing staff member might easily spend more than 2 hours in any 24-hour period with that person, or a family member. Usually with PT, we're not going to be spending that much time with them in a 24-hour period. They also need to limit contact with infants, children, and pregnant women and pets. They need to flush the toilet twice after each use because their excretions are radioactive as well. They need separate utensils and towels, and no kissing or sexual contact for at least a week. So lots of precautions for internal and systemic radiation. This person is probably not going to be coming to outpatient therapy, but we might see them in inpatient therapy. So early adverse effects of radiation which occur during treatments, you might have changes to radiosensitive tissues like the mucosa, the stomach, the small bowel, colon, vagina, and lymph nodes, and salivary glands might have permanent damage. Fatigue is a very common early adverse effect. It tends to worsen a couple weeks after starting treatments and typically improves within days to weeks following treatments. Reddening of skin across radiation sites may become permanent as darker pigmentation in that area. Late adverse effects can take months to years to develop. So you might get fibrosis where normal tissues change to scar tissue from the radiation, and you can get changes to organ function if they're doing radiation across your chest. So chemotherapy, or chemo as we call it, works by attacking and killing rapidly growing or replicating cells. It's a cytotoxic approach, meaning it's toxic to living cells. So cancer cells replicate quicker than most normal cells. Unfortunately, other cells that rapidly replicate are impacted by chemotherapy too. So lining of the mouth and intestines, hair, that's why you often lose your hair during chemotherapy, and blood cells. So chemotherapy may be used as a curative, supportive, maintenance, or palliative. There are over 100 different chemotherapy agents, and they're usually given in combination. Most people are taking a combination of 3 to 4 drugs that are accomplishing this cytotoxic process. So chemotherapy may be given orally, topically, subcutaneous injection, intra-arterial or intravenous injection, or intraperitoneal injection, so into the peritoneum. Patients may receive chemotherapy in an inpatient or outpatient setting. So inpatient settings are common for liquid tumors. Induction chemotherapy is used to induce remission, and it usually involves a hospital stay of 3 to 4 weeks. Consolidation chemotherapy, the hospital stay is generally 5 to 7 days. So outpatient chemotherapy is far more common, and it's often administered through a peripherally inserted central catheter, or PICC, or a central line, which is a Hickman catheter, or a port. Oral chemotherapy may be in pill or liquid form. Lots of precautions for chemotherapy. So because chemotherapy is often given in an outpatient setting, we might have people coming into an outpatient physical therapy setting who are undergoing chemotherapy. So that's something that we need to know. Chemotherapy is toxic, and it's a systemic treatment. It's all throughout the body, so all blood and body fluids, including sweat and saliva, are toxic. So for the first 48 hours after receiving chemotherapy, the person needs to close the toilet lid and flush twice every time. They need to use separate utensils and towels. They need to use paper towels to dry their hands and discard immediately in a closed garbage can. Soiled sheets and clothing should be machine washed twice in hot water. And if they're not washed immediately, they need to be placed in a sealed plastic bag, because sweat and saliva are toxic. Any absorbable undergarments need to be sealed in a plastic bag for disposal. So lots of precautions. When you have someone in outpatient therapy, I have someone right now, they need to wear gloves, you need to wear gloves. Any equipment that they touch needs to be sterilized before and after they use it. So lots of precautions. There are activity precautions as well. So high dose and high frequency chemotherapy causes drops in platelets, neutrophils, and red and white blood cell counts, leaving the person at high risk for infections and complications. That's why my patients need to wear gloves, and I need to wear gloves, and sometimes a mask. Until all the blood cell counts are within normal range for fighting infections, the patient must avoid exposure to pathogens. And it impacts all aspects of daily activity, including exercise. No weightlifting or strenuous exercise if the platelets are lower than 50,000. So just no, you can't do it. No weights greater than 9 pounds if they have a central line implanted. It's because you can dislodge the line. So that's an exercise precaution. The side effects for chemotherapy, they may begin immediately. If they're having an adverse reaction, it's considered an oncologic emergency. So, but chemotherapy side effects may also develop days, weeks, or months, or even years later. So the side effects might resolve soon after the treatment ends, or they may last for months or years, or be permanent. So the reason why there's so many side effects is because of the toxicity of the chemotherapy itself. So cells that normally rapidly divide, mouth, intestines, hair, and blood cells, the cancer cells, the chemotherapy is really supposed to break the cell membranes. And it changes functioning to normal cells. So we'll talk about cardiotoxicity, which is a potential side effect of chemotherapy. And it occurs because of changes to functioning normal cells. Plus, it causes decreased efficiency of all the organ systems. So it's a serious thing. So side effects that the patient experiences may include nausea, vomiting, constipation, taste changes where things don't taste the same, and loss of appetite. Skin sensitivities and loss of hair, fatigue, very common side effect. Pancytopenia, which means pan is all, cyto is cell, and penia is low. So reduced red and white blood cell counts and platelets. So all the blood cells are affected. They all have low levels, leading to fatigue and other things. Cardiac changes can lead to cardiac myopathies. Nerve and muscle changes, including neuropathies, weakness, and pain. Cognitive changes, particularly difficulty with attention and memory. Psychological mood changes, and lots of other things can happen as a result of chemotherapy. So the individual patient has to take a lot of precautions too, whether they're at home or wherever they are. For hygiene, they can't use a toothbrush because those mouth tissues are so much more sensitive. They can't floss. So they have to use an oral rinse and swabs only while they're going through chemotherapy. They really shouldn't cut their fingernails and toenails until the platelets are over 100,000 and white blood cells are within normal limits. So there's a potential for uncontrolled bleeding. For the same reason, you want to avoid sexual activity because you can tear those epithelial tissues, and until the platelets are over 100,000, it's dangerous. So in home management, the person undergoing chemotherapy should not do any what are considered to be dirty chores, such as putting dirty dishes in the dishwasher or sink, dirty clothing in the washing machine, sweeping, mopping, vacuuming, handling trash, cleaning the litter box. If they're walking their dog, they shouldn't pick up the dog poop. Somebody else needs to do it. Leisure activities, walking outside, they want to avoid stirring up leaves, and they want to avoid windy days or wear a mask because there are potential pathogens in soil, leaves, and blowing in the wind. No gardening, and that includes tabletop gardening, and that's because of the pathogens in soil. Pets. Some oncologists will allow people to be around their pets if they're clean and their shots are current, but they still won't be allowed to be around the litter box or changing litter or picking up feces. So if they have pets, it really affects them. Another treatment, hematopoietic stem cell transplantation, HSCT, otherwise known as bone marrow transplant, is used to regenerate a new immune system. So basically, they use chemotherapy to kill off the bone marrow, and then they transplant new bone marrow into it. So there are two categories, autologous and allogeneic. Autologous is it's your own cells. Stem cells are removed from the person while they're in remission and kept frozen. Then the person undergoes high-dose chemotherapy to kill off the old stem cells, and then they replace them with their own cells that were kept frozen. The allogeneic, you get donor cells from another person, so the person undergoes high-dose chemotherapy, and then they receive those donor stem cells. So basically you have to kill off all the old stem cells and get new ones, however you do it, from your own or from somebody else. Lots of side effects. You undergo that high-dose chemotherapy just prior to bone marrow transplant. So all the side effects of chemotherapy that we just talked about, those apply, along with a higher risk for infection and diseases, because the newly formed immune system is less robust than a newborn baby. And beginning around 3 months post-transplant, that you have to re-get your childhood vaccines because you're building a new immune system, basically. You're starting from scratch. You're saying, okay, this immune system is not working out for me. I got to kill it off and start a whole new one. So it's like you're starting off as a newborn baby. So you'll go through the same childhood development post-transplant. With allogeneic transplant cells, there is a risk of graft versus host disease, where the new immune system actually attacks the person. The immune system views the host as foreign and begins attacking systems and organs. So that is unfortunately a really bad risk. After your bone marrow transplant, precautions typically last for 100 days if you get your own stem cells, and a year if you get donor cells from somebody else. The reason for the precautions is it's a brand new immune system. So you have to avoid exposure to pathogens because the immune system can't fight infections, and exposures can quickly become life-threatening. The precautions include dietary and activity precautions and avoiding dirty chores and activities similar to chemotherapy precautions. You just have them a lot longer. So lots of other therapies. Hormone therapy has been used for a really long time. They started using it first in the late 19th century, and it continues to be used today for breast and prostate cancers. And it's usually given along with or after the primary treatment, and usually administered by injection or pill. So for those tissues that are particularly sensitive to hormones, hormone therapy is used in conjunction with other treatments. Targeted therapies work by interfering with specific cancer cell molecules to prevent growth and spread. Sometimes it's called precision medicine or molecularly targeted therapy. Most of them are either small molecule drugs, small enough to enter the cell and block the processes that the cancer cells use to multiply and spread. And they're usually taken as pills. Monoclonal antibodies attach to the outside of cancer cells, and that's usually injected. So it gives the body a way to identify those cancer cells as non-self, like we talked about in the immune chapter. The difficulty with targeted therapies is the cancer cells can mutate and become resistant to them. They can say, oh, I'm going to get around that. So there are lots of other therapies that are being developed, so it's an interesting area, new cancer treatments. And if you keep up with some of the sources that I talked about in the first lecture, you can find out about some of those new therapies. Patients with advanced cancer are often malnourished. There are lots of contributing factors that change in taste, where things taste different. Anorexia, which is a diminished appetite, vomiting or diarrhea from treatments, sore mouth or loss of teeth, pain and fatigue, and just malabsorption caused by inflammation of the digestive tract. So a lot of times their therapy includes nutritional therapy. Complementary therapies, besides the ones that are directly treating the cancer, include massage, meditation, counseling, exercise, therapeutic touch like Reiki, and some of the other therapeutic touch things. There's a group, there are people that believe in a raw food macrobiotic diet for cancer, but there is not really research-based evidence that's been published for that, or for the use of insulin and glucose with chemotherapy. But as healthcare workers, we need to be aware of these different types of therapies to help advise patients. So a lot of cancer centers, like the cancer center that we have in Bellingham locally, includes all these different complementary therapies, and they have people that can work with patients on finding the right thing. They also have recreational therapy, art therapy, all sorts of different complementary therapies. So they're not directed towards the cancer, but they're directed towards having a better life while you're getting free from the cancer. So continued advances in treating cancer and improved methods for earlier detection have led to improved long-term survival rates. So the 5-year relative survival rates rose from 48.9% in 1975 to 69% in 2011. So that's a big rise. Cancer used to be considered, way back when, it used to be considered a grave disease with no significant curative options. That was a quote from something that was published in the early 20th century. But in 2014, there were an estimated 14.5 million people living beyond a cancer diagnosis. And this is expected to rise to almost 19 million by 2024. So that's awesome. Cancer is no longer the thing that's going to kill you. It's something that you can fight. The 5-year relative survival rates combined for all cancer sites, all races and both sexes. So that's that first bullet point. So different cancers have different survival rates, but that's the combined for everything. A huge improvement. So a bunch of different references. I'll let you read through them. And in the next section, we're going to talk about physical therapy.